The gut is, by the way, from the esophagus down to the anus. Is that the gut?
It's really the mouth, Alexandra. It's the mouth. Digestion really starts with salivary, amylase, and lipase. I mean, the ear, nose, and throat docs claim the mouth, but there's a little overlap. So it is, you wouldn't come see me if you were having a dental problem, but technically speaking, the mouth is part of the digestive tract too, all the way down to the anus. Yeah.
Okay, good. So I remember the first time I heard about the microbiome, it was not too long ago, maybe 6-7 years ago. And I was blown away because what they were talking about was the fact that when babies were born vaginally, they had a whole different set of health promoting bacteria in them than if babies were born from C-section. Can you talk about when the microbiome is first formed and what we've done to screw that up and what we can do to make that better?
Yeah, that is exactly right, Alexandra. So if you've ever been at a live birth, many of us don't remember when we gave birth because we were busy trying to get the baby out and not be in pain. But if you've watched a video or an animation or you've been at a birth, what you'll see for a vaginal birth is that as a baby's head crowns, it turns posteriorly to face the tush. And it does that to swallow a mouthful of microbes because that area between the vaginal opening and the anus, that area we call the perineum, is full of microbes. It is one of the most microbially rich parts of the body. So as a baby's coming out, it swallows a mouthful of the mother's microbes, and those important microbes become the founding species for the baby's microbiome. Now, babies that are born vaginally have that benefit. Babies that are born via C-section don't get that opportunity. And as a result, they are colonized with hospital-acquired Staphylococcus aureus instead of the mother's healthy bifidobacterium, etc. And what that means is that those babies born via C-section have higher rates for 4 things: for asthma, for autoimmune diseases, for allergies, and for childhood obesity. Just because of that difference with the hospital-acquired staph versus a mother's microbes. So these are important differences. And, while some C-sections are done for really important reasons, sometimes to save the mother's life, to save the baby's life, we know that somewhere between 1 in 3 and 1 in 4 births in the US are done by C-section. And we know that a pretty significant number of those are done for convenience and for commerce, and not because that is really what needs to be done. So, what day, what time, you can control it. But, my argument is a process that takes 9+ months should not be rushed. It takes that long for a reason. And the baby lets you know when it's ready to come out. But in my second book, The Microbiome Solution, I wrote a whole birth plan about, how to prepare the microbiome before conception. These are the things to talk to your team about: vaginal delivery, not sterilizing the baby when the baby comes out, all of these things. And my OBGYN friends hated me. They were like, all these women are coming in and they want to do everything natural and it's the biggest pain in the neck. And why did you write this? But I wish I had that plan when I was pregnant 17 and a half years ago when my daughter was born. It was a C-section. She got antibiotics at birth. She was minimally breastfed because my breast milk dried up from all the antibiotics I had been given. It was a disaster. And nobody told me, and I don't think nobody knew. I don't think any one of those physicians, including myself, had any clue about the long-term effects of what was going on. So I think, we all have an obligation to educate each other and to bring the information to the forefront so that people can use it. And, if you have to have a C-section, so be it. But if it's just being presented to you as an elective option, you need to know that there are consequences, particularly if you're somebody who has an autoimmune disease or has a history of an autoimmune disease in your family.
What are some of those thoughts and tips for mothers that are listening to this that are going to give birth in a couple of months? What should they consider?
Well, the first thing to know is that make sure that the C-section is necessary and it's not an elective C-section. Okay, so you're having a C-section because the baby's breech or the baby's in distress, etc. Number 1. Number 2.
Let me interrupt you 1 second because I've got a personal know somebody personally that is electing to have the C-section because of an autoimmune that they have.
Well, the C-section, the babies born by C-section have an increased risk of autoimmune disease.
Right,
now,
right.
If she has an autoimmune disease like Crohn's disease, where sometimes there can be fistulas, rectovaginal fistulas, there can be things going on in the rectal and vaginal area that could lead to a tear or a problem. Sometimes they need to do a C-section for that reason. So there may be more technical reasons there, but just having Crohn's does not equal a C-section. And in fact, should we try and avoid a C-section in that case because of the potential increased risk to the baby? So it's important to make sure that this C-section is truly medically indicated, number one.
Because the hospital,
number two,
it makes more money, the hospital, if it gets a C-section.
The hospital makes more money, the doctor makes more money.
Right.
Sure.
Okay.
Yeah, absolutely. And remember, C-section is surgery. So you have potential complications like infection, blood clots, bleeding, death. I mean, it's rare, but you don't want to have surgery if you don't have to. The second thing is about antibiotics when you go in, you sign a general consent for care, and so that they don't have to come, oh, can we do this? Can we do that? I mean, you're in labor, right? This is not the time for 20 questions, but you need to make it clear that you don't want to be given antibiotics during labor, which are going to go through the placenta and often get to your baby, unless they're absolutely necessary. So no prophylactic antibiotics. If you have an infection or the baby has an infection, so you want to be clear about that. You want to understand the risk of labor-inducing drugs. And, again, full disclosure here, I'm just a lowly gastroenterologist. I am not a gynecologist or an obstetrician. So these are my perspectives as a gastroenterologist. Everybody needs to talk to their own doctor about this. But labor-inducing drugs that help to speed up labor are often associated with an increased likelihood of C-section. And that's what happened with me. And now it may be that they need to speed up labor because it's taking too long, the baby's in distress or whatever. But if it's taking too long, then people just need to be patient. If it's taking too long and the baby's in distress, that's different. But often, I went in at, it was like 2:00, and at midnight, the baby was not there yet. And people start to get, a little like, okay, it's, it's time, but it's time when the baby's ready, And so that's the thing, like these labor-inducing drugs can sometimes increase the risk of C-section. The epidural, which I was so grateful to get. And the funny story, I had my baby at Georgetown. I was on faculty there, and the medical student came in to sort of prep my back for the epidural. And then one of the supervising physicians, who I knew well because I worked with him in endoscopy. In fact, I think I had done his colonoscopy. He came in and he was like, no, get out of the way. Like, VIP patient. She's a faculty member here. I'm going to do it. The funny thing is, at that point, if one of the hospital janitors had walked in and said, I'm going to do your epidural, I would have been like, great, have at it. Because I was in some serious pain, like, labor pain varies. When people tell me, oh, it was all natural, I'm like, it was fine. I mean, I was in serious pain, and nobody had ever told me. And again, I trained at good places. Nobody had ever told me in medical school or afterwards that epidural that is going to dramatically alleviate the pain is also going to increase your likelihood of a C-section. And, had I known that, because I really wanted to avoid a C-section, had I known that, I might have made a different choice. I mean, it was painful, don't get me wrong, but I likely would have made a different choice. And so again, what we want people to be able to be really effective advocates for their health. And without the information, you really can't advocate, right? You just assume that this is all going down because it needs to, and it's, all a great idea. And, again, even for me as a gastroenterologist, gone to Columbia Medical School, did my GI fellowship at Mount Sinai, chief resident, I knew none of this.
Now, I also heard in this original story that I heard about the microbiome that you can swab the vagina if there is a C-section, and then swab the baby with the vaginal excretions so that the baby gets the microbiome. Is that something that you recommend that somebody asks for?
Well, this is something called vaginal seeding. And Gloria Domingo Belez, I think I'm getting her name right. Her husband, Marty Blazer, was the head of infectious diseases at NYU, and they've both done a lot of great work in the microbiome. She's done a lot of this work in South and Central America, looking at this process of vaginal seeding. And it's super low tech. You literally take a piece of gauze, and, it doesn't even need to be sterile gauze, because the whole point is to get it kind of dirty. And exactly what you said, Alexandra, you put it in the vaginal secretions down in that sort of perineal area, and then wipe the baby's head, mouth, etc., to sort of approximate a vaginal birth. And I talk about that in my birth plan, but I also say, be sure to discuss this ahead of time, not when you're in labor, ahead of time at your prenatal visit. Because if you start doing this, they might call security on you. They're busy sterilizing the baby and wiping off, that's also something I talk about in the birth plan. Like, don't take that Physoderm, Hexaderm, whatever it is, and wipe off all the microbes. That's, you want that. So it's important, if you are going to do vaginal seeding, that the team is aware, and we have some good data for it. There are a few studies that suggest that it may not be helpful. You have to be aware of, what's going on vaginally, and make sure that, you're doing it correctly. But it's a super low tech procedure. It literally costs you the pennies that the vaginal gauze, that the piece of gauze cost. And it can be really, really helpful particularly for somebody who's having a C-section, who is concerned about these risk factors, asthma, autoimmune disease, allergies, obesity, et cetera, for their kid. Let's say they have a personal history. Let's say your friend Dotsie, who has autoimmune disease and has been told she needs to do a C-section. That might be something really appropriate for her to discuss with her care team.